Christina Buerta, Manager of the Centre for Constitutional Rights. So tonight's topic of discussion is the National Health Insurance Bill. So we have invited experts from diverse fields who will be unpacking the implications of this quite technical bill, and I think it's quite topical considering submissions on bill is due tomorrow, and I'm sure a few more people are working on their submissions tonight. So I think it will be quite interesting to hear our experts' view. So just a little bit of introduction or background to the NHI Bill. So it has actually been in the running for quite a few years. We're actually in the second phase of NHI. The pilot phase was already lapsed in 2017, and currently the second phase involves proposed legislation such as the NHI Bill. So the NHI Bill proposes the establishment of the NHI Fund, which is a health financing fund, and which envisages it's described as a single payer purchaser, which will purchase and buy all health services for the entire population. So tonight we've got Michael Settas from Free Market Foundation, who's written extensively on NHI and specifically on South Africa's health policy. He's got a long background in medical aid schemes, and so it's quite interesting to hear his perspective also from Free Market Foundation. We've also got, very fortunate to have Russell Rensburg from the Rural Health Advocacy project. It's in partnership with Section 27, and I'll be quite interested to hear his perspective from the community as well. So ladies and gentlemen, as always, these events will not be possible without our sponsor, the Konrad Adenauer Foundation, a German political foundation who's been supporting us for years. And in that regard, I quickly would like to call on Ms. Christina Teichmann to say a few words, and then we're going to start. Michael will follow. Thank you very much.
Good evening, ladies and gentlemen. It's a real pleasure to be here tonight and to welcome you all to tonight's discussion on the topic National Health Insurance Bill. A special warm welcome to our two guest speakers, Michael Settas from the Free Market Foundation and Russell Rensburg, Director of the Rural Health Advocacy Project. I also would like to thank the CFCR, Christine, Rebecca, Megan, for organizing this event. It's the last one for this year, and some of you have attended a few of these discussions, and I think they're always organized perfectly, and it's always a pleasure for us as Konrad Adenauer Foundation to partner with you. Tonight's discussion comes at a time when state-owned enterprises like South African Airways and Eskom and other parastatals are in a deep financial crisis and close to collapse due to bad management, cadre deployment, corruption, and lack of oversight. The trust in the state to manage these facilities and enterprises successfully is therefore at an all-time low. The lack of trust overshadows the debate on the introduction of a national health insurance bill, and many people ask themselves what the introduction of this bill will mean for the quality of treatment they will receive in future at hospitals and doctors' rooms. While a restructuring of the health system is a legitimate objective, and most of us would agree that it is high time for all South Africans to get access to decent health care, there are some questions that need to be answered. What is the future role of private healthcare and medical schemes? What are the costs involved when introducing the National Health Insurance Bill? And most importantly, who pays for this insurance and the services that are included? I'm confident that our two experts will provide us with some answers. Lastly, I would like to say a few words about the Konrad Adenauer Foundation and what we stand for. Konrad Adenauer Foundation is a German political foundation affiliated to the Christian Democrats in Germany, and we operate in 120 countries worldwide with the aim to promote democracy, good governance, and the rule of law by funding research, publications, and events like this one tonight. We have learned in South Africa, but also in other countries, that democracy is not a given, and that democracy needs to be constantly protected and guarded, especially by the media and by citizens, by all of us, basically. Citizens need to inform themselves, they need to be vigilant, and they need to hold politicians to account. And I really hope that events like this tonight, and also the discussion series in general, will assist in achieving this objective. So I wish us all a fruitful evening and an informative debate. Thank you.
Good evening, ladies and gentlemen. As Christine said, my name is Mike Settas. Thanks for the opportunity to come and have a chat here tonight about national health insurance. We have some technical glitches going. I'm going to use this one, is it okay? Not working. Oh, there we go. Okay, so on that point, these are the thoughts for today. So I'd like to touch on something called universal health coverage and what the objective is with regards to NHI. A look at our public sector, competition in healthcare and why it's necessary. And then lastly, most importantly, political influence. I'll see now things are going blank, but anyway, here we go. Hopefully the health system works better than that. Okay, universal health coverage. Is it turning off?
That is preview.
Yeah.
And that's next.
Yeah.
And that is when you exiting the slide. Make sure please don't touch this too, just touch only this.
Yeah, okay, good. Thank you. Okay, so universal health coverage, this is probably the biggest issue for me in terms of how the NHI has been posited and how it's been presented to South Africa. The important thing about it is it's not an entity, it's not a thing, it's a policy objective. And that is to provide healthcare to everybody. And most countries achieve universal health coverage in a variety with using a variety of mechanisms, not just one mechanism that provides universal healthcare or health coverage to citizens of a country. NHI in and of itself is just a funding mechanism, and there's absolutely nothing special about it. There are many all over the world, and they have multiple variants. And the interesting thing, though, is that as far as the World Health Organization is concerned, South Africa already has universal health coverage. It gives us a coverage index of 0.67, 1 being perfect and 0 being non-existent. If we look at the world average, it's 0.64. If we look at the averages in the wealthiest countries in the world, Europe and North America, it's 0.77. And sub-Saharan Africa is substantially poorer than South Africa itself at 0.42. Obviously, 1 is the perfect ideal, but it's not possible to get there, but in essence, we're not really doing too badly in that. Well, the system is available, the structure is available, but the last point here is really what the issue is that South Africa's public system is really, the delivery of the management of delivery and how that is happening is really problematic, and there are a variety of reasons as to why that is the case. Let's just touch on the basis of NHI. What is government actually proposing? So what it is saying is the private sector spends an amount of money on healthcare, and that equates to 4.4% of GDP. The public sector then spends another 4.1% of GDP, that being tax funded. And if we take these two pots of money and throw it into one NHI fund, then we'll have 8.5% of GDP, and we have lots of money to give everybody healthcare. Sounds great in principle, but very seldom does socialism actually ever work well. The point is that the money on the right, the public sector, is 100% tax funded. The money on the left is 100% privately funded. Massive overlap between the two people who pay those amounts as well. So effectively, this would be the equivalent of government saying that you can't have private schools, you can't have private security, because we actually got to take the money that you spend on that and put it into a pool that we're going to manage. Okay, so that's very concerning in terms of what the thinking or the ideology behind it is. So the numbers I'm going to present here are in 2018 values. So if we take the 8.5% that government wants to achieve, the public spend of 4.1% will be pumped up to 5.5% of GDP. And the way in which that will be done is taking the current Department of Health budget of 226 billion, removing tax credits for those members of medical schemes, which gives about another 25 billion, and removing the state subsidy that the government gives to its employees to belong to medical aid, and that's about another 35 billion. So then we have 286 billion rand. And then the balance of 3% to take the whole spend to 8.5%. And this is a point now to be raised through the fiscus. So essentially what that means is more taxes. How that's going to be achieved, I really don't know in the current fiscal state, but that's what the numbers pan out to be. I will emphasise that government's done no extensive costing around NHI, so we're as much in the dark really about it as they are. These are the numbers that they put together in both the green paper and the 2 white papers that came out. And that gives a public entity, a state-owned enterprise, that's going to manage 450 billion rand every single year. Okay. SA's public health sector. Let's have a look at this. I did a little exercise. I just thought I wanted to see how we compare with other countries. So what I did is I took South Africa's per capita GDP and I pegged it on the far right of this graph. It's on the red bar. And then I took all the countries immediately above it, with their per capita GDP being higher, up to a maximum of twice our GDP. So that gave me a cohort of 31 countries. And then when I said, okay, well, let's have a look now. What is our public health spend? And I emphasize public health spend out of those 31 countries. And South Africa then moves up from last position to 14th position out of 31 countries. So in comparison to our peers, our immediate peers who are wealthier than us, we are spending relatively more than on public health than they are. Not the highest, but as you can see, we've moved up into the third quartile of those same 31 countries there. Purely as a matter of comparison. Government's problem statement is this, and this is the same message that was given by the previous Minister of Health, is the first highlight of yellow block is shortage, that obviously being shortage of doctors. And this is, and that obviously the budget hasn't increased in real terms for the past 10 years, and this has impacted the number of staff that can be appointed, presumably in the public sector is what he's referring to. So I thought let's give that a little bit of a test. So the numbers that I'm going to show you now don't come from me. They come out of a document published 2 years ago, jointly by National Treasury, an international NGO called FHI 360. We focus around access to health, and the KwaZulu-Natal Department of Health. So in March 2006, there were 140,000 medical personnel employed by the public sector. And I emphasize employed, these are not posts that are necessarily available, these are actual employment figures. 2 years later, that had moved to 155,000. 4 years later, that had moved to 192,000. And by March 2016, it had moved to just short of 200,000. So in the space of 10 years, it's a 42% increase in the number of medical personnel employed by the state. Okay, now I'm not suggesting by any means that we have enough doctors or that they're appropriately spread, but there's been absolutely no problem in the public sector in terms of being able to attract medical personnel. And I haven't put the budget figures in here, but if you're going to have a look at the spend on healthcare, it's increased, in real terms it's increased over that space of time. And it's obviously natural to have been able to attract the personnel and numbers that I'm looking at there. So I would sort of press the point is, where's the minister getting his numbers from if he's saying we have a shortage or we can't appoint more doctors? Because clearly if you look at those figures, and as I say, they're not mine, they come from Treasury, from the Department of Health. So let's have a look at the two major factors in terms of measurement of how effective a healthcare system is working, and that's infant and maternal mortality rates. And I compared this to a basket of upper middle income countries, of which South Africa is one. And if we look at both the infant mortality and maternal mortality rates, we really do not fare very well in terms of comparisons to those other countries. Okay, now this obviously can be very traumatic for families that have to go through this in terms of losing a child or losing a mother at childbirth. If we look at our disease burden as measured by the World Health Organization, and remembering that disease burden is relative to how good your health is being delivered. So if your health system is working well, your disease burden will come down. If it's not working well, your disease burden goes up. So out of 196 nation states that the United Nations classifies, we rank 19th highest in the world. Okay, now that's very concerning. Obviously, we need to try and bring that down to improve the health status of the country. I want to focus now on this slide here, the Office of Health Standards Compliance. For those who aren't aware, this is a department within, or an office within the Department of Health that you can kind of equate to a clinical auditor general. So they will come and assess and measure facilities in a range of metrics, right through from food to clinical to hygiene to availability of stock. Outcomes is a whole range of metrics. And from that, they then produce an inspection report each year. We haven't seen one this year. I'm not sure we're going to, but the latest one is the one that was published last year. And out of that, they inspected 696 public facilities. So they don't get to everyone in one round of reports, but this gives us a good idea. So the scorecard looks like this. On the right, you'll see there's 6 categories there that the facilities score in. The top is good, you'll be happy there. At the bottom, you want to go and find another facility because it's really not working that well. And remember this very important point. So what is being said in the NHI Bill, as well as in all the papers that preceded it, is that for a facility to qualify to contract with NHI, they have to score 80% or more. So what that means is if they do not score that, they cannot contract with NHI. So in other words, what it means is that the revenue into that facility then under NHI is 0. There's no public budget then to fall back on to say we're going to get money from central fiscal allocation. You just fall out of the system entirely. Well, that's what the bill says. We obviously haven't seen it tested yet. So let's have a look at the scores then of those 696 facilities. Okay, obviously not a very pretty picture. We have 1% of facilities. The actual number is 5 out of 696 that qualified, that met the 80% mark. Okay. So what this means is that 99% of public facilities, as they stand right now, will not qualify to contract to deliver services under the NHI. So the questions we have to ask is, surely an NHI bill is not important in the context of fixing this. Rather, let's focus our efforts on fixing this, as opposed to creating a bill which says we need an 80% scorecard, but 99% of facilities are not going to be available to contract with. So it really doesn't paint a very good picture. It also creates another problem, and this is a financial problem which the country really can ill afford, and that's called medical malpractice liability. Now, I think virtually every health system in the world will have some element of medical malpractice in it. It's the extent of which it occurs that really becomes the problem. And in South Africa, we have a substantial and growing problem in this regard. That's the history over the last few years of the total liability that is sitting on the government's balance sheet. This year, it's just short of 100 billion rand. Now, we're obviously not talking about small change here. So this is a liability that government would have to pay out at some stage. Not necessarily maybe all of it, certainly not in 1 year, but it's very much like the Eskom problem, except that government's not been given the opportunity to say, will you guarantee this debt or not? They have no choice on it, because when a court says, bang, you've caused harm to a family, you have to pay, there is no choice around it. Now, the National Department's entire budget, which gets allocated down to the provinces and the districts, is 226 billion, 225, I think, I'm not exactly sure. So the liability is sitting at 43% of the entire annual budget. Now, ask the question, at the rate that that's growing, and you can obviously work out for yourself very quickly where that trajectory is taking it. What happens when that gets to 200 billion and 300 billion? Remember that Eskom's debt is sitting at 450, and it's a crisis that could sink the country. So this is another crisis that we really need to get a handle on, and if we don't, the Department of Health is going to have a major, major problem on its hands. Nothing in the bill has been said about this. Nothing. Absolutely zero. Okay. Insider views. Let's just take it instead of me standing here saying what I think. The Health Ombudsman. These are the words that he used last year. The Auditor General was even more blunt about it. Okay, and they're obviously at the coalface on a lot of these things. I want to touch on the health market inquiry. This was a almost a six-year inquiry that focused around, that investigated and inquired in the private sector. Now, it may seem odd why I'm talking about that now in the government, but the issue is that private sectors also need to be regulated and need to be managed and given a structure in which they operate and function properly. So on the Department of Health, the health market inquiry had the following to say. It said that there was inadequate stewardship for the private sector. Its failures were not using legislative powers to manage the private sector, not holding regular reviews as required by law, not holding regulators sufficiently accountable, and subsequently the private sector is neither efficient nor competitive. So what you have is a situation here where this inquiry has found that the Department of Health has ultimately been somewhat delinquent in terms of its duties towards the private sector. I've obviously showed you the slides prior to this about how it's managing the public sector. So it's really not a very good indication of what the public sector, what the government is doing in terms of managing health, both public and private. So the concluding questions on this section I'd have for you is, should government have more involvement in the arrangement of healthcare for citizens? It's not doing a very good job in either sector. And the key issue for me now, and this is my real concern, is should it also hold a monopoly on healthcare? Because remember what government is saying is that only the NHI will be able to deliver in a basket that it's delivering. Private sector will then be squeezed out. So it's quite odd if you say you're not doing so well, but I'm going to give myself a monopoly so I can do more of not so good stuff. So I'd like to touch here on competition in healthcare and just give you some examples. And the reason I want to give you that is because this has been the rationale for NHI from the beginning. We can have a single payer, i.e. monopoly NHI fund, with nationally centralized procurement, and that will reduce costs. Now, I don't even really need to go into it. We'll go into the monopoly versus efficiency and reduction of costs is a misnomer. It does not exist. All monopolies, whether they're public or private, do not meet those ends. So let's test that rationale. If we look at the British National Health System now, often people who want to create these national health systems like the NHI will go to British NHS and tout it as saying that this is the benchmark by which all national health systems can be run. But the NHS has gone under substantial reform over the last 30 years. In the late 80s, the British government realized it wasn't working very well, costs were rising, quality was reducing. So they introduced a number of reforms. One of those is citizens can choose their funder being a district health authority. So you don't get allocated to a DHA in the UK, you can actually choose your own. It would be almost like choosing your own medical scheme if you like, but you have choice around it. Patients also have choice around their provider. So if they don't like the specialist, they don't like the hospital in their area, they can actually go elsewhere. And the bottom line around this is that money followed the citizen or the patient. So funders working in the system and providers working in the system are now not concerned about how they're going to contract with the NHS. They go, okay, the NHS is there and it's telling us for us to get funds out of the NHS and to survive, we have to fix the citizen or the patient. So it introduced all the elements of competition into the environment to create a system that resulted in this. And I'm not saying the NHS is a perfect system. It has its failings. But from that point to where it's come today, outcomes have improved, waiting periods have reduced, and costs have declined in a number of areas in real terms. So the issue here is that they went away from a centrally controlled system to create more competition within the system and improved circumstances. As I say, NHS is not a perfect system, but we can see the relevance there. Let's go other side of the Atlantic. Here we have Michael Porter, who's Professor of Economics at Harvard, and he has this to say: history tells us that monopolies that are truly benevolent and effective are rare. I don't really think anyone needs to tell you that, but it emphasizes the point. And his emphasis around his book, Redefining Healthcare, his down a whole round of work, is on competition in healthcare. So that you have to bring competitive forces into it to make it work properly. And he's put his money where his mouth is with this particular association, which he started with a number of colleagues, the International Consortium for Health Outcomes Measurement. And what this is the approximately 12 or 13 countries that are participating here submit all their health outcomes data to a centralized point in which other providers can actually peer review and see how the other doctors are performing in it. So if you yourself are a doctor and your data is going in there and you're at the bottom of the list, you're going, oh geez, I'm not doing so well. How do I get up the list? How do I improve? It's not a punitive system, so it's about sharing the data in order to get it up. But the key issue is it creates competition within the system, and then everybody shares data to see how we can improve on that. I'll get closer to home. Professor Alex van den Heever, who's been a long-time critic of this NHI, but he's also been extensively involved in public policy and healthcare over the years. And he just says quite simply, the bill's proposing to centralize what should be decentralized. The purchasing function should not be placed within a national structure, as this is too distant from delivery and will institutionalize massive inefficiencies. I think he was being kind with the word inefficiencies, because I think he's probably referring to what's been going on at the Zondo Commission for the last year and a half or so. But I think we kind of get the point on it. So the concluding questions I would have here is, should we not rather have a decentralized public structure with regional authority and accountability? And I would possibly add to that and say competitive forces to ensure that delivery is improving. But don't we already have such a public structure? Our structures are already decentralized down into the regions and district health authorities. They may not be perfect, But I think much can be done in terms of the management of those structures and how those funds are distributed, where the doctors are allocated in terms of improving them. But certainly moving away from this to a centralized structure is not going to bring about those efficiencies. So my last point here I'll touch is this one over here, the words political influence. So I think all over the world that kind of covers all manner of sins. So no less though in South Africa. So let's have a look at that. So the fundamental flaws of NHI and why I say that there's political influence all over it. It creates an absolute monopoly for itself. It centralizes procurement and accreditation. So imagine that there, I think, are 8 or 9 committees that are proposed under the NHI Bill, and 2 of them are about procurement and accreditation. So who gets to supply what, at what price, when, and accreditation, who gets to be accredited to actually deliver services. So imagine 2 competing facilities in a region. One gets accredited, one doesn't, but maybe there's some sort of discussions behind doors as to who gets it and who doesn't. There's no separation of powers. It gives an absolute monopoly to the fund. Political appointees, as we've seen the problems with this in terms of the history of the last 10, 12, 15 years possibly. There can be no public accountability on that basis either. The other major issue is that there's been virtually no technical or policy analysis around this NHI proposal. The ministerial committee, NHI committee, has been in place since 2009. It's 10 years. We don't know anything. We really have left with very little. The only thing we have seen is the pilot sites. So the evidence we do have is they all failed. The minister said they weren't failings, they were learnings. So I suppose rose by another name, but anyway. And it's fiscally unrealistic. I mean, to take 9 million people who cover their own private care and to say to them, we're going to take that away, put you into the system, and then use the tax money to fund it, makes absolutely no sense whatsoever. We should be looking to grow the private sector to alleviate the pressures on the public sector. And you see that in virtually every country that has systems like these, that they will give incentives to the private sector to grow rather than to be the other way around. This whole point about the medical schemes being squeezed out. What's also concerning is that in the face of all this evidence is that the NHI is spoken about in almost evangelical terms. Like, once this comes, we're going to live forever because it's just going to be total panacea, silver bullet. I mean, there's a whole lot of other terminologies being used on it as well. So when I look at political influence, I only had to find these 5 SOEs to sort of create some measure of what could possibly go on. All of these are pretty much dysfunctional. And what we really don't need is a 6th block at the bottom now that says National Health Insurance in it. Just last week, the Auditor General announced that he'd completed his audits and that the SOE is in the worst financial state that they've ever been in. So whilst we get the sense, we think that things are getting better, we're hearing Zonda, we're hearing the New Dawn, the evidence is not showing that things are getting better, possibly worse. But let's look at possibilities versus probabilities. I'll take a quote from Bill Clinton, who understood that in his '92 election campaign, in which he said, it's the economy stupid. And I think what he was trying to say, which I believe in many ways, is that economies control governments. Governments do not control economies, or they can have very limited impact in economies. So when things go bad, governments tend to get changed. Maybe not in South Africa, but we'll it's another issue altogether. So SA government debt is now, I think it's sitting around 60%, and if the projections that we heard in the medium-term budget speech that Buweni gave just recently, that could rapidly get to 80%, which is very concerning because of these 2 figures. The budget deficit's over 6, growth is at half. I mean, if those 2 were reversed, then I'd say maybe we'd be okay because we could eat into that debt, but at this rate, that debt's just going to grow. The budget deficit alone is going to add nearly 2% a year to the debt. So that's besides the bailouts to SOEs and everything else that comes with it. Inflation and interest rates also remaining high. So all those metrics are in the wrong direction. We have, and they obviously exacerbated by these issues. The SOE bailouts, the corruption, which still hasn't been addressed, and I think we're a long way from being able to sort that. And the other concern, which I think South Africans don't even really touch on it anymore, it's the brain drain, the skills we've lost. We see it now with Eskom. in which there was a purging of all the old existing engineers in the system. Now they're not sitting with the skills that they need. They can't fix the systems because they don't have the skills. So we can't afford that either. But anyway, I thought I'd borrow this from Brandon at the business day. I think it was 2 weeks ago. The elephant's not in the room, it's sticking out through the roof. And that's the problem, is the state wage bill. So unless these things get arrested, our economic situation is going to get worse, in which there isn't going to be a chance of healthcare improving no matter what system we have, whether it's NHI or otherwise. I'll leave you with this cartoon over here. And the reason I liked it was that the NHI, as you can see there, is labelled as the chainsaw. Because I feel it is a chainsaw. It's a blunt, rough instrument that's going to cause a lot of damage to not only the taxpaying South Africans, but all South Africans. So the conclusions I would come to are, from 2006 to 2016, we had a 42% increase in the number of medical personnel employed by the state. So there was more money, there were more doctors. Outcomes have not improved. Things have not got better. Now, remember that the principle of what NHI is saying is, give us more money and we will give you better healthcare. But they've just proven they weren't able to do that. So I'm not sure that we can really trust that. We certainly absolutely cannot afford another tax or more wastage of taxpayers' money. And the governance structure of this NHI bill is deeply, deeply flawed. The way in which it's structured, I quote a colleague who said, even if this bill was structured like this in Switzerland, within a year you'd have corruption. Okay, just to emphasize a point. The only realistic option really is to fix both sectors. And that's only one line in my presentation here, but there's an enormous amount of work that can and should be done in terms of getting the two sectors together. To wait for NHI to supposedly magically fix something which we don't believe it's going to, means that the government is ignoring the low-hanging fruit now to go and fix the systems now as to what we've got and actually bring healthcare to people. I'll leave you with my last slide. I touch on this quite often. I take Brazil as an example. They have the world's largest public health system. It's called the SUS. It covers roughly 3/4 of the population. Most of the public primary care facilities, most primary care facilities are owned by the public. Most hospitals are privately owned, but the SUS purchases care from both the public and the private facilities to provide the healthcare. And right next to that world's largest public system is the world's second largest private healthcare market, second only to the US. There's a sense of this that is pragmatic and real, rather than saying, we're going to take over everything and run with it. Let's share it between both the public and private sector to provide healthcare. Thank you very much for listening.
Michael, for breaking down the figures. I think it was quite interesting to see, and you took I love graphs, can't do it myself always, but I love actually how you broke it down, and it is alarming, and I think we have a lot of questions for you later on. Can I please call on Russell to come forward? Russell, we've got your piece, you've got that.
Okay. Good afternoon. Good evening. My name is Russell Rensburg. I work at an organization called the Rural Health Advocacy Project. Now, I had prepared a couple of slides, and some of my slides are duplications of what Michael said. But I think I want to start with the story. You know, there's an institute at the Massachusetts Institute of Technology, also known as MIT, and it's called the Narrative Institute. Right? It's got to do with something called narrative framing. And there was a conversation at the London School of Economics where they had the director of the Narrative Institute coming up and having a conversation. And what he did was he told the story of how advocates in America went around decriminalizing marijuana. And so they were tasked with this job of saying, like, listen, why is public interest in marijuana legislation the way that it is? And why are certain people so opposed to it? Right? And then what he did was they kind of analyzed where all of the problems were, which were the people that were worried about it, and turned out that a lot of the Southern Belt states were diametrically opposed to the idea of decriminalizing marijuana. The goal of their project was to look at incarceration rates, because there were so many African Americans who were incarcerated with marijuana-related offenses, and they thought if they decriminalized marijuana, they could decrease incarceration rates. So then they called up a whole lot of disc jockeys and opinion makers in the South, and they wanted to understand, like, why are people so opposed? And the findings were surprising, you know, and what it turned out was that when everybody typed in marijuana into Google, the images that came up were images of urban youth, of crime, of guns, of gangsters, and everybody had associated marijuana with this group of people. What they then did is they approached Getty Images and they changed all the stock images for marijuana. Right? Then all of a sudden they had ladies in yellow cardigans sitting on their porch at night, having a cup of tea and having their marijuana cigarette. We all know that this is history. Today, one of the most drug-averse countries in the world, and probably got the most progressive legislation around recreational marijuana use and medical marijuana use. And I think the point that I'm trying to make is that we all look at things in different ways, and sometimes it's just a matter of perspective. Right? And I think the slide that I want to open with is, this is the reality of South Africa. I think this is now an infamous picture. It was part of the World Bank's Incomplete Transition Report, featured on the cover of The Economist at one point and Time magazine. But the reality of South Africa is that South Africa is a deeply unequal society. You know, post-apartheid South Africa has actually seen inequality deepen rather than narrow. You know, in many cases, previously advantaged people are more advantaged than what they've ever been. You know, since 2015, we've had increases in poverty rather than narrowing of poverty. The private sector, for all its efficiency, hasn't created jobs for over 40% of the population that have been perennially unemployed. Most of them are between 15 and 35, young, black, and poor. 67% of them don't even finish matric. Right? And I think this is the kind of country that when we look 25 years ahead, and just on our demographics, we're going to have a massive challenge. Corruption is the least of our worries. Unemployment is the biggest worry in South Africa. And our ability to create an inclusive growth story really relies on the strength of our public institutions. I think nobody can argue that the last 9, 11 years was probably like a masterclass in corruption. Right? I think every particular approach that we could take to reprogramming the state budget towards politically connected people, we did. You know, and a lot of the stuff, the strangest thing is that was in line with the law, but not in the spirit of the law. You know, one of the biggest reforms that we need to look at is maybe procurement reform. We don't do a market test in our public procurement. We just sit down, we have a tender committee, 3 people sit around a room, they evaluate quotes. There's no assessment as what is a market test as to what is the market price for that thing. So we ended up overpaying for a lot of things. And I think just the transit stories are one to go by, but you know, in hindsight, everything is 2020. But we do have an opportunity now, in the 25th year of our democracy, to start reimagining the kind of country that we want. You know, coming back to our demographics, you know, our taxpayers, as some people like to euphemistically say about our previously advantaged group, who pay all the tax because they have all the wealth and all the income, are aging, right? Their kids are moving overseas and becoming digital migrants. And maybe looking 20 years ahead, our demographic pyramids will look very different. And the wealth that we want to hold on will be eroded. So we have to start a conversation of patience and start looking at what are the kind of public investments that we can make that can drive our country forward. Now, when asked about inequality, this is what Victor Sula, a senior economist at the World Bank, had to say. You know, he said the people at the bottom in South Africa get the wages comparable to the people who live in Bangladesh. I've been to Dhaka. It's probably one of the most difficult cities that you could ever be in. It's very poor. You have wages of less than $50 a month. And if you make it to the top 10%, you live like they live in Austria. And I think whenever I come to Cape Town, I'm reminded of that this is a country of many stories. And the lives that we live in, I was fortunate enough to have an apartment in Rensburg early in my career. But when I first moved to Cape Town, I lived in the Cape Flats, and I spent 2 hours on a bus coming to work every morning. I bought an apartment in Rensburg, and all of a sudden my life changed. Every morning I'd leisurely walk down to the office, had a cup of coffee, and it was like I lived in a different world. Right? And I saw all the people being bussed in, and in the afternoon all of them get bussed out again, and the city changes. So South Africa is a country of many stories. But we're here to talk about national health insurance. And I think national health insurance is problematic insofar that everybody that has an opinion has a different opinion. And very people have actually sat down and read the book and looked at what they talk about progressive universalism or what is the problem that they're trying to fix. Now, we invest handsomely in health, particularly in the public sector. You know, in 2000, many people were dying. We had this onset of a disease called HIV and AIDS. You know, it overwhelmed our health system. We lost healthcare workers, we lost people, and we lost a lot of productive capacity. Right? And we had to find a way of coming back from that. You know, today, HIV still dominates public sector health expenditure. So the private sector spends the equivalent of what we spend in the public sector, covering 15% of the population, who are essentially just having diseases of lifestyle, cardiovascular diseases, and so forth and etc. In a very much consumer-driven health system. So you go to the doctor, you ask the doctor for this, he helps you, you want to see a specialist, you want to see a specialist. There's no referral pathway, there's no contribution to public health. It's literally just the health you want, when you need it, where you need it. But it's all based on your ability to pay. In the public sector, there are over 4 million people that receive monthly or chronic medication, particularly around life-saving HIV and AIDS. And in that sense, you know, some of our indicators have actually started going up. You know, our life expectancy now is over 60. It was 50-something in the early 2000s. It's a massive improvement. You know, our maternal mortality is still amongst the highest in the world, but it's a third of what it was. You know, so unfortunately, then it also depends where you live. If you live in the Western Cape and you're born in the right place to the right family, you probably have a better chance than a woman living in rural Umtato, which is the areas where we were, of surviving a pregnancy. Right? And I think that kind of inequality is something that we as a society can't perpetuate. You know, and I think it starts with that fundamental question of what is health? Right? What would you, like, you know, is health a commodity that we can trade and we can concentrate and we can decide who can have it and who can't? Or is health a public good? You know, that belongs to everybody. And I think that's sort of the fundamental question when we think about health reform. The private sector is a very healthy business. You know, when you look at the balance sheets of Mediclinic or you look at the balance sheets of Discovery, they're making a good mint servicing a very small portion of the population and over-servicing. That's the other bit that the Public Health Market Inquiry found that Mr. Settas chose maybe to ignore. And I think Alex van der Heever does the same thing when he says the government failed in its regulation. But the government didn't encourage all of those health executives to decide, listen, how can we make the most bucks out of you because you have the money to pay and your insurance will cover. You know, hospital admissions in the private sector is amongst the highest. And part of the reason is because that's the part where the funding's locked up in. You know, other thing about over-servicing. So we found out, depending on your medical aid scheme, will depend on the kind of treatment that your doctors or your team of doctors would give you, because it's a very large group of professionals chasing a very small population. So they're going to try and maximize the money that they get out of you. But the NHI is not about anti-public or anti-private. I think when we look at it from the perspective of universal health coverage, and we look at it from the perspective of progressive universalization. So universal health coverage is defined as ensuring that all people can use the promotive, preventative, curative, rehabilitative, and palliative health services they need of sufficient quality to be effective, while also ensuring that the use of these services does not expose them to financial hardship. Now, South Africa does well when it comes to co-payments. We have John Atikuba from University of Cape Town did a study on the level of co-payments that South African makes, particularly lower income. And we have no service fees in any of our public health facilities. In the private sector, however, despite all the money that we spend in it, some figures suggest that we spend as much as 70 billion rand a year in co-payments or contributions or things that are not covered under your medical scheme. Right? That's a significant amount of money that you're paying for something that you're technically insured for. But really, in terms of financial hardship, we do relatively well. But what we don't account for is the cost of getting to the healthcare service. Right? So in the rural communities where we work, which are quite widely dispersed, they're large, they've got difficult topography, small population numbers, dominated by old people and young people. Access to healthcare is actually not as easy as just stepping down the road and going to see your GP. Right? And because of the way that funding is structured, even in the public sector, a lot of the money flows to the cities. So we have a lot of capacity concentrated in one place. But the sooner we move out of the cities, and unfortunately not everybody is like the Western Cape, where we have a very strong network of small towns, feeding through a road network and all converging on Cape Town. But when you go to the Eastern Cape and you travel maybe 100 k's out of Port Elizabeth, it's a totally different country. When you go to Johannesburg, the city looks fantastic, but you drive north 50 k's or you drive south 50 k's, you move into a totally different country. You know, and I think that's part of the challenge, is that we need to make sure that we have consistent healthcare availability for everyone. That doesn't mean that there doesn't need to be a private sector. I think we just have to organize our resources in such a manner that we service the needs of the people that need it most. Often the money that we spend in the private healthcare sector is healthcare that we could have avoided, you know, that we didn't need to spend. This is the Center for the Constitutional Rights. You know, I think one of the fantastic stories about South Africa is that we sat down, and between 1992 and 1996, people from different persuasions, different perspectives, and different opinions sat down, and they set a gold standard of aspirations that we as a country want to achieve. We recognized that our past was far from perfect, and in some ways our positionality allowed us to live a kind of life that wasn't afforded to all. Now, the Constitution is like a budget, it's a declaration of intent. You know, that we start off with some base principles of the kind of society that we want to build and we want to protect. Now, when you look at this, we don't say the right to health, we say the right to health care, which is essentially more than health, it's a set of entitlements. We were saying to people that health is important to you, and then we isolate particular rights, like the right to sexual and reproductive health. You know, we have a teenage pregnancy problem in our rural areas where young women can't access comprehensive sexual and reproductive health services. It means that they are robbed of their economic potential, they don't finish school, and they are forever vulnerable, and then we hear these stories about young women being killed, and then we think a legalistic response is the only response. Sometimes the health sector responds by making sure that we have those necessary services available can empower women more than giving 3 life terms to a murderer, as necessary as that is. Right? But our Constitution is quite clear where we say everyone has the right to access healthcare services, including reproductive health, sufficient water, social security, if they are able to support themselves. We often talk about in some of these rooms about our large social wage, but the only people who can qualify for social grants are the elderly and the disabled, right, and young children. It's 400 rand. The upper poverty limit to survive per individual in South Africa is marked at 900 rand. Our grant is at 400. And then UNICEF and global studies talk about the fact that if we don't have sufficient nutrition in the first 1,000 days or first 5 years of life, it impacts our developmental potential exponentially over the period of our lives. So sometimes simple investments early in life can actually add more productive capacity to the economy. You know, and I think we have to ask ourselves this question: do we want to concentrate our economy within 25 or 30% of the population, hope to grow that incrementally every year through economic growth? Or do we want to start looking at a story where we can activate that youth dividend by creating pathways into sustainable employment? And investments in healthcare is sometimes an opportunity to invest in that human capacity and capability. The payoff won't be this year or next year, but over time, we might start creating a broader consumer base that will increase aggregate demand and will make the people from the free market foundation very happy as the profitability and profit opportunities expand. But the state has the responsibility to do that, and part of the NHI legislations is trying to meet that responsibility. You know, when we look at the health market, you know, and we say, yes, everybody has the right to purchase private healthcare, and I didn't really plan for this presentation to be some kind of rebuttal on some of the challenges that are out there, but I feel duty-bound to speak a little bit about it. Yes, there are many healthcare workers in South Africa, and I think it's very difficult. We spend about 14 billion rand a year from fiscus training healthcare workers. You know, this year we're going to be 1,800 new doctors will join the system, and as we go down, there are quite a few of them. The problem is that we don't retain them. So we spend a lot of money, of the taxpayers' money, to invest in medical schools and the like, and we train health professionals, we train doctors, we train nurses, but at the end of the day, we can't absorb them because the cost of employing in the public sector is too high. And I think it's one of the structural challenges that we have to face. 47% of a public sector wage is actually benefits. Right? And I think something like the NHI introduces an opportunity of contracting in capacity rather than just having to employ. So you could employ double the amount of people when you contracted in a health professional rather than giving them a job. So one of the sites of struggle, the NHI is not a perfect or the panacea for the problems that we have in our health system, public or private. But what it is an opportunity for us to start reimagining how we look at healthcare. And I think maybe let's start the conversation around how healthcare is funded at the moment. It's a deeply political process. So our revenue is collected nationally from taxpayers like yourself, Mr. Settas. Right? And all of the hundreds and the millions of South Africans who pay VAT and buy petrol and all of those kind of things contribute to our fiscus. That makes up at least 30% of national revenue. And that everybody pays, not just the 15% of high income earners. But needless to say, all of that gets distributed into a national revenue fund. That revenue is then divided horizontally between national departments. The National Department of Health gets around 56 billion of that. And then around 196 million or billion is distributed between the 9 provinces. Right? They use something called what they call a provincial equitable share. And what that is a sort of a composite index made up of various population dynamics, economic output, poverty, migration, and all of that. And they deposit it into the accounts of provincial governments. Gap in our constitution, maybe, is that we don't place any limitation. The provinces have a fair amount of discretion of how they allocate those resources. And sadly, what's been happening since 2012 is that we've had a general decline in the way that we finance healthcare. So if you look at the funding, and I think in the South African Health Review that comes out, there was a paper from National Treasury that showed that our investments in health have literally stayed the same when adjusted for inflation since 2012, and our population growth has gone up. Right? So we've underfunded healthcare services for a period of time, which has led to the collapse in the healthcare services that the health ombudsman spoke about, and that was very specific around the care for mental health patients in the life is a really crisis. And sadly, we only spend 5% of our total health budget on mental health, even though it's one of the biggest growing diseases. But besides the struggle for us around the NHI Bill is the issues of governance. Right? The other thing is around population coverage, who is covered and for what. Then is around allocative equity, where the money lands, are we allocating the money efficiently. Currently the bill doesn't allow for this fund to have some kind of distributed model. It just says that the National Health Insurance Fund will be responsible for buying all healthcare services and so forth and etc., but it doesn't really continue that constitutional prerogative of equitable distribution. So it's a gap for us, and it's something that we need to look at. The second thing is around population coverage, and particularly here we talk about undocumented migrants. One of the founding principles of our country is that South Africa belongs to all who live in it. And while we understand, the need to protect healthcare services for the South African citizens, sadly, there are also families of undocumented migrants who are ordinarily resident in South Africa and have been here for a long time. Right? And so to automatically, through the stroke of a pen, just simply exclude those people would be immoral and unconstitutional. Our right to health fits within a realm of progressive realization rather than regression. And excluding people who are currently covered from cover would essentially amount to a regression. Right? Around the benefit design, again, like I said earlier, I think we started with the premise that our public sector actually provides quite a broad range of services. Right? And I think we need to protect those entitlements. And lastly, it's the service delivery models. And I think this is probably the thing that we've spoken about the least. Do we have a strong public sector with some buying in of private capacity? Or do we have a system where we completely contract out the delivery of a public good like health? Which is probably one of the perspectives in which would necessarily be better for some of the hospital groups who are probably sitting at around 30 or 40% efficiency at the moment, given that there are 300 public sector hospitals. There are more private hospitals and public hospitals servicing a very different population. So I think at the end of the day, those guys are not making those investments sweat. So when it comes to governance in health is very different from corporate governance. Corporate governance, we know even that can fail. I mean, recently, everybody here from Stellenbosch will know about Steinhoff and how that makes us feel pivotal. The one that's less reported is the issues with Tonga Hewlett, where Mr. Stassen and his mate also made off with a ton of money, despite having a very strong board. But governance is more than just oversight, and sometimes governance is something that happens in hindsight rather than in the beginning. But leadership and governance involve the WHO, which is the World Health Organization, talks about leadership and governance as strategic policy frameworks that exist and are combined with effective oversight, coalition building, regulation, attention to system design, and accountability. Now, accountability is beyond just financial accountability. It should also be program accountability, because the core business of health is to deliver health, not necessarily just to run budgets. It also considers how power is distributed between institutions, public and private, and the exercising of authority, as well as the various means and regulations which citizen groups have to articulate their interests. We are a citizens group, or we derive our mandate from the Constitution, and we advocate for the equitable access to healthcare by rural populations, and I think we are allowed to do that. The current governance frameworks derive from the National Health Act. And again, I think if we take a little bit of time to read Chapter 4 of the Health Act that looks at the governance frameworks that are in place, there's a number of different things there that we should be looking at optimizing rather than taking away. I think one of the flaws in the NHI Bill is that it takes away a lot of that national health governance that currently exists. So a lot of power is concentrated in the minister, and he loses the benefit of getting the advice of the various provincial departments of health, MECs and HODs. And I think for the NHI to work, to have some kind of provider perspective included in the oversight of the fund would really just add value to the fund rather than diminish it. Right, so the NHI is not the panacea to the health system, it's a financing instrument. And I think when you look at it as a financing instrument, it addresses a problem that we're fixing now, and it's allocative inefficiency. Right, so problem depending on where you live or depending on how services are delivered. You know, and I think in some ways by having all health funding concentrated within the NHI fund, it's not a deliverer of services, so it doesn't have a monopoly over delivering healthcare services. It finances services, and it's monopsy rather than a monopoly. But it's an instrument that essentially depoliticizes health. So instead of a provincial MEC deciding or provincial premier deciding how to allocate healthcare funding, at least in theory, the fund suggests that funding is allocated based on need. But as a funding mechanism, it changes the way that health is delivered. Right? And I think this is where Alex and I have a difference of opinion. Right? I feel that the system is decentralized more under the NHI. Because instead of having money flowing to provinces, and provinces then deciding how to allocate or prioritize health, we're sending health directly to where our health is delivered, which is at the sub-district. You know, so primary healthcare and so forth and etc. But then this issue of public interest comes into question when we start looking at the composition of the NHI board. You know, when you look at the Act, that Act really veers towards technocrats. So you have health economists and actuaries and people with some kind of medical interest who will oversee this board. Often people that have never used the public service, so they'll have some gaps in perspective. And I think one of the areas we think it can be improved is by allowing for citizen groups to actively participate in the governance and the design of health systems. While we recognize the minister's role as the steward of the health system, and the health system in the National Health Act includes both public and private, and I think he failed in the second instance, and I think it's now common knowledge that we could have done better to regulate the system, but that doesn't excuse some of the betrayals of trust that happen within the private sector. So just to abdicate that responsibility to the government, I think, is really not necessarily the best way to go about it. We introduce or expand the powers of an existing body. Currently there are district health management councils. They fall under the provincial administration, but they're also tasked with delivering healthcare services. So the introduction of this district management office is new, and in some ways it's a little bit problematic because some of the problems that we have in some provinces could be now replicated at the provincial level. So while much of the attention is on the power of the minister, the real site of struggle is actually at the district level, where there will be significant or no oversight whatsoever, and officials can act with want. But generally we feel that governance can be strengthened by citizen participation across the health system. Again, I think I covered this a little bit, population covered over my time. Everyone has access to healthcare services, right? The current National Health Act doesn't explicitly exclude undocumented migrants. So excluding them from coverage will essentially result in some kind of regression. And I think we should rethink about how we approach the coverage of people that are vulnerable but are currently not South African citizens. I touched a little bit on the issue of allocative equity and really just like looking for measures that we can ensure that the National Health Insurance Fund buys the services we need at the level that we need them and for the populations that need them. So when it comes to benefit design, I'm going to sort of end my presentation here and not run through all the other stuff that Michael already showed us around maternal mortality and so forth. I think what I wanted to demonstrate that depending on where you live, the outcome looks very different. But in the benefit design is actually where the rubber hits the road. What we are arguing is that we should actually first look at what the basic health entitlements are, and in defining the package, not try and shoot the lights out, but rather look at how we can ensure that we design a package that delivers the healthcare services that people need, where they need it, and those who are most in need. And instead of looking at coverage from a point of view of getting rid of medical schemes, we should rather prioritize delivering that comprehensive package to those people that can least afford it, and then over time expand coverage of the package to other groups. And I think in that way we can have a win-win. I don't think that the government has the capacity or even the ambition to take over the private sector, right? And I think some of the numbers that they put out there is almost political. You know, when they look at a full implementation of the NHI, it's in the term of the new government, which is 2026. So it's something that lies without their power, and if you look at current political performance, there's no guarantee that the current government will be the government there. You know, so I think at the end of the day, it was really just putting a mark in the sand and understanding that our country is deeply divided. There's lots of biomedics. This health bill is more than just about health bill. Health, and I think is really something that we should all go around and champion, not because we believe that healthcare services should be the provider of the state alone, but rather look at it as an investment in the social solidarity that we need to take our country forward. Because it's clear that, you know, if we continue in the same path, we might not have a country in 20 or 25 years. So I think when we start looking at the NHI Bill, we start have a change of perspective. And let's not be driven by the fear of having to go to some kind of public sector facility and wait for 2 days in order to get the care that we need, but rather look and see how can we find a middle road, right, that ensures that the people that need the care that they need, they can get it where they need it, and that we develop some kind of progressive expansion of this package so that those who choose not to use public services or enroll in the fund can be added as time goes on, because I think that's going to happen anyway. You know, and I think if you look at other legislation like the skill development taxes, I think at the end of the day we didn't see them as a development opportunity. Businesses eventually just paid the tax. And I think with the national health insurance, there is a risk that at the end of the day we're going to pay the employment surcharge, but we're going to make other plans to deliver healthcare services. We'll go back to the mind doctor. So instead of every business will have their own little consultant who will provide that. And I think we need to change the story. So in my opinion, I think this is a progressive bill that allows an opportunity for us to address everything and not just healthcare. But it's something that we all have to work together, and in the spirit of partnership and negotiation, dialogue that our country is built on, rather than taking binary positions that can only deepen divisions rather than unite us. Thank you.
Thank you very much, Russell. Red or black. We specifically wanted experts from different fields to give their perspective on NHI, and that's exactly what we had today. I think, you know, you come from very different experiences as well, but what I specifically found from your speeches or from your statements today is you know, a recognition of a stark inequality in healthcare services. No one can deny it, and we need to urgently find solutions. And I think that's what Michael said, and that's what Russell said. You had much more overlap in perspectives than you would, you know, which doesn't necessarily look so from the PowerPoint presentations. So if I can ask Russell and Michael to come and have a seat, and we're going to have our Q&A. So I'm going to take 4 questions to start off, and yes, and we'll see how it goes. We've got a roaming mic as well.
Hello, I haven't had time to think carefully about the question, but I'm speaking to both of you, more particularly Russell. I have to, first of all, I'm also going to tell a story. I'm an attorney, and I'm a family law attorney, so I'm not very well
not divorce.
Yes, divorce is very important. But okay, so what I'm saying is, I was at Attendees on Wednesday for facial surgery, and I saw an excellent specialist there, and I have always gone to Rensburg, and I can't fault them. It's a wonderful hospital, but it's in the Western Cape. We're very lucky to have it, and in other parts of South Africa, it's the medical health care available is shocking. But what I'm saying is, I tend to be a bit of a socialist thinker, and I consider myself to be an African socialist. So I enjoy.
So you and I are in the same WhatsApp group.
We're in the same. But I understand that the business people and the economists like Michael, they're very worried about their money, particularly their income that's going to go towards paying for medical care. And I think, wouldn't it maybe be a good idea if you said to them, okay, you don't have to come and you don't have to rely on our healthcare system. You can have your expensive doctors and your medical aids and things. You can have it, but you still have to pay a percentage of your tax, because this is Africa. This is not Europe. It's not America. And particularly in South Africa, where we have an appalling history that's caused, abject poverty and that needs to be addressed. That needs to be. And I think that your 5 basic things that you need, you have to have healthcare, you have to have education, you have to have food, you have to have shelter, and you have to be clothed. The poorest of the poor have to have all those things. And I think the people that have big houses and go on overseas holidays, they can just give a little bit
They work hard for
to
it.
the people that need it.
We're not.
Okay.
Yeah.
That's it.
Okay. Are we gonna take them one at a time?
No, let's go first, and I'm writing it down as well. So.
I'm going to leave it at 7:30.
Okay, so we can, yes,
Okay.
if you don't mind.
So let me
I think that's
look. I think we are saying the same thing. I think a lot of the stuff is in the subtext.
I was just
Right.
the idea of
Yeah. When we look at the actual bill, right? When they talk about, and you read it. I mean, a lot of us base our opinions on the opinions of experts and whoever's framed in the media, and I think all of that has got a very specific job. It's meant to agitate us, scare us into action. But when you actually read the bill, I think they're quite realistic. They know that it's a phased implementation, right? They set a date, but the date's not set in stone, right? And I think all of it is really just about coverage and how we negotiate coverage. I think at the moment, I often, you wear glasses, right? It's a story I often use. Is that, it's a very small investment, and ITIS is the cost of a Nando's meal nowadays, right? But we don't employ enough optometrists in the public sector, and we also don't have a modality to contract them in. We either have to employ them or we don't have access to the service, right? So with a contracting mechanism like the NHI, you can actually contract in an optometrist. So a kid that's sitting in school feeling stupid because they can't read the board can now just have an eye test and get access to spectacles, and their lives can be transformed. And they can actually be the next Michael Settas and become a successful businessman. But without those spectacles, they will be treated like stupid for their entire lives. So I think the idea is to sort of build a base package that the people that need it most can access it. And then over time, we build the capability, and then we expand coverage. But we may have a situation where you'll pay the surcharge, but you still also pay your medical aid, and you won't get the tax credit that you need. In fact, the provisions of the bill at the moment allow that if you skip a step in the referral pathway, you're not covered by the fund, and it's like a backdoor opportunity to allow medical schemes to continue. I don't think that medical schemes will end in the next 25 or 30 years. But really, I think the principle of the bill is around social solidarity. And it's us understanding that we must unlock opportunities for everybody.
Okay, is your question answered?
Thank you.
Okay, yes, I saw his hand just here.
Russell?
As Anya.
Russell, we're here because we all realize that South Africa has to make certain changes, and I'm just worried that your whole plea here is a very, very eloquent plea on the Zimbabwe model. Now, I don't want to threaten or be depressing, but you know, we're making a terrible mistake because it's got to happen, and everywhere in the world this NHI is happening, but we must be honest before we do anything, and we must find out what's wrong with the present system. And you must first address that. You must be honest about these things. Stop dreaming of nirvana. We're living here now.
Yes.
As we sit here, people are dying because our system is shot. And we're not admitting it. We're not accepting responsibility. It's tough, they're dying. Oh, sorry. But it's not how it works. So the NHI is we're designing a plane, and actually we need a bicycle. And we must be honest about this. But politicians have been promising this to the citizenry. And we've been talking here about child mortality, but we give a woman 400 rand a month to have a baby, and she thinks it's enough. So we're feeding a system in at the bottom, which gives us unlimited soldiers for the war, but that's not life. So I've been involved with the medical aid, the government's medical aid for 6 years, and we had a couple of projects, and we go to Umtata. You mentioned Umtata. You don't talk about Groteski, that's not fair. This is where it comes from. But go to Umtata, and we went 3 years in a row. You know what it costs to take a board of trustees to Umtata 3 years in a row?
A ton of money.
To see nothing happen, because you've got to be connected by internet. There's no internet. There's no electricity. There's no anything. So we must park this NHI business and fix our people, and then we can start fine-tuning once we've got it. But we must first fix it, and it was the first thing that Michael said. We've already got it. The guys at GEMS who say what you must do with your money, they say we've already got it, but it's not working. So we must be honest that it's not working, and we must fix it.
No, we agree.
And then we must, but it's not about then, we must fix it. And we must start looking after our people. We're not looking after our people. We're talking clever stories, but we're not, I'm not attacking you.
No, you're not attacking me.
We must look after our people.
Mr. De Vries, I would argue that if you change your perspective, you'll see that by continuing to do what we're doing now, we're actually not looking after our people.
Yeah, but how many people are going to die first?
Okay, sorry. So let's. I actually wanted to ask a question. Sorry, I'm going to monopolize my opportunity here, because we've also, from the Centre for Constitutional Rights, we've also looked at the bill, and an aspect which I haven't heard anyone mentioning tonight is lack of information, actually, which I think you touched on. I mean, you said, you speak about how it's, actually the NHI Bill, there's a lot of, plans and so on, and implementation will take a while, and, there's a lot of positive aspects, it's not all, depends on your perspective, it at least gets us to start talking about problems. But if you, I'm an attorney from my background, so I'm a very, white person in that regard. But if you look at where we are now, we're already at the point where we have an NHI Bill in public participation process in Parliament, in the National Assembly. And the information given to the public, there isn't a lot of information to work on. So, I mean, critical information, that's our reasoning behind it, is you don't have any information on the costing. I mean, you're working on 2010 prices. You refer in your memorandum to actual costing models, which the public has no insight to. So that's already, I think, what touches on Michael's point is, but that's where fear is generated, because you're not giving the public information to actually to work on it. And which I also think creates fear is we don't know what all benefits they're looking at, healthcare service benefits they will be provided. They say it will be provided and set out in regulations. It should have, rationally, it should have been, information should have already been on the table in order for us, in order for your public to actually say, okay, how will this affect me? Okay. How can I comment on it? So I think that's where, I think NHI, so it's just maybe just a comment on perspectives.
I think that's a very valid.
Yeah, it's just your public at this point where NHI is, it's pushing, and it's a parliament's face already at National Assembly because it's being promoted as a solution, and we don't have information. We don't have information on our pilot projects. There's been reports, but you don't have department's perspective on those reports. So I think it's just being pushed ahead at a point where we're quite fearful.
Can I respond to that?
Yes.
And I think, Michael, I think you've done quite well in getting us all to get our passports up. Look, I think the reality is that they started this process at the wrong time. In 2012, the introduction of the pilots was just after the World Cup, but which in a lot of ways helped us through the global financial crisis in 2008. Right? We survived that because we had that fiscal expansion as a result of the World Cup. We had all that money coming in, and after that, growth just dried up. Right? And we got some real pressures. When it comes to costing, you can't cost something when you haven't agreed what it is that you're going to deliver. And I think the notion that they took is that we're already spending 240 billion. We're already offering quite a wide array of services. But what we need to do is change the organization around how we deliver it. So they're saying that the current budget envelope is the initial budget envelope. That's what the legislation says. Or at least the legislation proposal says that we're not asking for any new money. We're not expecting to ask for any new money. What we will do is we'll take current financing arrangements, consolidate it, reorganize it, and then see what we can deliver within that. Right? So I think for me, the costing, you can't add what you spend in the private sector to what you spend in the public sector and say, okay, your budget for national health insurance is going to be 480 billion. I think it's really maybe, I think if you want to scale the living daylights out of people, you do that. Right? I think the thing that we do know is that we have an inefficient system, both in the public sector and in the private sector. Right? And I think we had 25 years of history, we've had some shocks. There's many things that we don't know. But what we do know is that we've got X. We do know that our current service organization is not optimal. We do know that we have excess capacity in the private sector. Right? And I think what we've got to figure out collectively now is how do we chart the path forward so we can get Mr. De Vries to start relaxing and realizing that we're helping the people on the ground first by expanding the access to services. Because yes, the public sector can employ as many as they like, but if they can't afford to employ them, then it means that places like Mtata or Karedo or any other rural town will be last on the list of places where you can get access to capacity. When you create funding envelopes at a sub-district level, right, you start, at the moment, those private practitioners aren't in those places because there's no medical aid coverage. Right, so there's no incentive for you to go and open up a GP practice there because there's no customers. 95% of the people there rely on the public sector. Now when you start reimagining that a little bit, and you take the same budget envelope and you say, at that sub-district in Nyandeni, outside our Tambo, you're now going to allow X amount of money to contract in some capacity. All of a sudden it becomes attractive for a young doctor to go out there, or for an integrated practice of a doctor that's set up in East London or in Port Elizabeth to rotate people in that space because there's actually a funding envelope to draw up and we can make a sustainable practice. But I think what we need to start doing here is stop thinking about the worst case scenario and use our considerable intellect, particularly the intellect in this room, and say, how do we take that budget, how do we break it up, and how do we deliver it efficiently based on what our service capability is to do. But we also worry about the costings because we don't know what we're costing. Right? I think our main priority right now is to reorganize healthcare services within the available budget and optimize efficiency and equity within the system. Because 240 billion rand compared to our peers is a significant amount of money. And I think there's a ton of inefficiencies that can still be mined. And I think we haven't put our attention on that. We've rather looked and said, okay, fine, let's add what we're spending now. And say, okay, fine, that's going to be the mark. Because I don't think that's the right way to look at it. But I think there are a lot of clever people in South Africa, and we can actually unpack it a little bit better. And you'll find that even our business sector will see there's significant upside opportunities, both for them and for the people at large.
Michael, do you have any comments? Sorry, Mr. Stewart, I see you also have a...
I think it's about my turn. I think one thing just to emphasize is that to the lady, I didn't get your name, but we're not against universal healthcare, anything but. I mean, we would want to see that absolutely be the best scenario for everybody. I mean, it is the objective, given that health is a social good, that every citizen should have access to a certain level. There are certain financial realities that we just have to deal with though. If you take every single country that grows in wealth will improve its health. It is an absolute universal fact. And I think the policy position that we would take is that the freer societies that are less constrained by government interventions are the ones where the best growth happens. It's absolutely universal.
China is not so free. They have the best growth. You know,
And the best health.
And they did it when they were poor. But so Michael, I think
but China's an oddity because it's
Japan,
it's a market
Korea.
economy within a socialist economy. But
one small comment. Thank you so much for answering my question. I just want to mention when you mentioned the British National Health. I think you'll find that if you look at the history over the last 10, 20 years, the National Health has worked when the Labour government has been in power. And the minute you have the and they've had the Conservatives in power now for quite a long time, and that is why national health is not working, and that is why education is not working. Simple.
ideologies, I imagine.
Sorry, Michael, I didn't see you. I think it's... we have a few more questions. Yes.
Thank you, Christine. I have met Michael. Good evening to you, sir. I am a politician.
I'm a politician, how are you?
And I sit on the portfolio of health in the National Assembly.
Yeah.
And I'd like to make a couple of comments from a political perspective, because I think it's great to hear perspectives of everybody, and that's why I'm here, because I want to hear other people's perspectives, and I want to deal with the realistically big picture. And just a couple of comments. We already have NHI. We do. Because in the poor and rural areas, people do not pay to go to a clinic or a hospital. They are already having their medical services funded for them. Is that not national health insurance? The other thing I wanted to say is, and obviously I've been dealing with this bill now for 3 or 4 years since I've been in the position that I am, it is strictly a funding model. It is strictly there to say how we will pay for those services. It is not a service delivery model. And you stated now that the service delivery remains in the hands of the provinces. And that already creates a problem. And I have been on the public hearings. I've done Mpumalanga, I've done Limpopo, as well as a couple of the other areas. And I want to go back to Christine's point, because the whole nightmare about this bill at the moment is the misinformation or the lack of information, and we're seeing both. I go to public hearings where people, and without a doubt, people have been mobilized. It's the way things work in this country.
They have the right to be mobilized.
Yes. Okay. Not necessarily politically, though.
Well, I think that's the whole purpose of having a free society, is that people are mobilized politically. You know, they don't have to all agree with you. But I think
okay, I don't necessarily agree that a public hearing must be a political rally, and we have seen a lot of that. But I want to get back to what people in those public hearings have said, and why we have two sides of the story. We will either come up to the mic and people say, oh yes, I support NHI. Wonderful. Because tomorrow I will be able to go to any hospital that I want to, any clinic that I want to, and I will be able to see any doctor that I want to. And the medical system in this country is an absolute disaster. And now me, poor person from the borders of Mozambique, can now go where I want, because that is the information that they are being fed in these mobilizations. So number one, that is not the situation at all, and we're not even close. The alternative is we hear, I support NHI, but, and you get the direct opposite. I will support it when I've got a clinic that's open 24 hours, that's properly resourced, that has got doctors' beds, that have hospitals that have beds, and things. And that's just part of the misinformation that we're dealing with at the moment. And it makes life very, very difficult, particularly for us who are sitting around the table trying to digest and break this down. So we have NHI already. We have a system that should be working that is not. And the lady who spoke previously said she goes to CFCR Hospital in Cape Town. And it's wonderful. And it is. Because you have a provincial government that takes that kind of thing seriously, because it is a provincial mandate. Okay, that doesn't apply everywhere else in the country. So it's commentary more than direct questions, and I think this is something that we must take into account.
But it's a matter of opinion, and I think I really just want to respond to the thing about government. And at the end of the day, one of the things we want to avoid with healthcare is the constitutional right, it's not a political right. So I don't think that I think the one thing that the Democratic Alliance did well in the Western Cape was to leave the managers that were there. You know, the ANC governed the Western Cape, and Krutowski was still working as well when they governed.
I didn't say it was run by a party. I said the Western Cape has been well managed.
It's implied. But I think the point of the matter is that health is an asymmetric business. Right? One of the findings of the health market inquiry was that people, and intelligent people like yourselves, don't understand your healthcare benefits. Right? You are presented with like 27 different packages, all covering prescribed minimum benefits, and you utilize maybe 10 or 15% of them. And you have no understanding of the cost structures. But the messages that you sold, whether political or not, is that you need this cover more than anything else. And I think that's one of the challenges with health, that all the power lies with the providers of health and not with the users of health. And I think one of the things that we need to do if we want to focus on anything is on health literacy. And health literacy, not just about health conditions, but rather how health works. Because health is based on a notion of scarcity. There's a Bowman law. They say the price of health, as an economist, like you, Michael, right, that really says that the function of health is because health is such a specialized business. Most of us turn off our ears and we don't understand it. Everything our doctor says we believe, right? Because he has the power and there's not enough information, or we don't have enough understanding of how health works, that we end up paying much more than what we need to. And that's why we need to regulate health or look at a way of delivering health that benefits everybody. When you talk about universal health coverage, I think many people believe we have universal health coverage. But there's different dimension to coverage. Sometimes just having a clinic or a service available, but if it isn't of sufficient quality, it might as well not be there. If it's not acceptable to the people that use it, it might as well not be there. Right? And I think we have to look at all those different dimensions. I'm not political, I'm apolitical, I'm a social democrat. We don't really have social democratic parties in our country, and I think politics is broken. Right? I don't think that we really have a political movement anymore, be it blue or green, right? Because there's no base structures anymore. We don't have localized politics. I mean, some of our political parties still use direct marketing campaigns to campaign for votes. We have very, very narrow political structures. The ANC government is run by 3,500 people who go to a national elective congress. The branch network is really broken down. I think part of the success of the Freedom Front was that they mobilized around localized issues. And I think as a society, one of our biggest challenges is stop making everything a binary, but start localizing our issues again. In the Western Cape, it would be about water management. Right? I was speaking to someone earlier, now that the rains have come, we've forgotten about day zero. Right? Because we mobilize around an issue, but we don't mobilize structures around an issue. And I think our opportunity going forward is building these little social compacts between politicians, business people, and community around the kind of country that we want, rather than getting caught up in a political diatribe of who says what, because there's actually no difference between political parties.
Can I comment on that if you don't mind?
Okay, yeah, quite a lively conversation here. But I think Michael, you want to comment quickly.
I think the evidence of that is that if we really keep politics out of the delivery in any system, you know, as to who is in rather than why they're in, we'll fix it. I mean, the Western Cape is a good example in terms of how the health system is held together far better than elsewhere. And it reflects in the fact that only 2% of the medical malpractice liability that the state's sitting with is in the Western Cape. 2% out of the whole country. Now it's very insightful, that, because it tells us that the system can work, the structure can work, as long as we've got the right people in with the right management. And I mean, Russell, from your point, I mean, I take it in any rural society, you're going to struggle to get doctors in. And it's not to say that it's the right thing, but it's It's you've got a young doctor who's just qualified, and now you're going to go ask him to work in a. They don't want to. Now, I'm not saying it's right or wrong. I'm just saying it's a challenge. It's a challenge in any system. Anywhere in the world, you're going to find that is a challenge. But yeah, I mean, I think we have examples in South Africa. I mean, even if you take within various provinces, you will have pockets of excellence where systems are working, like delivery is working well. We need to take those as learnings. I strongly believe that the way the NHI is structured now is going to be a disaster in terms of delivery.
I think we're going to have a difference of opinion around that.
Yeah, I think.
So I think let's not make it a dialogue around that.
We still have a few more questions. I think one or two, Mr. Stewart.
Is this thing on?
Yes, you can sing a song.
I think it's only fair that somebody should ask Michael a question.
Been waiting all night.
Tell me, how have the private sector hospitals fared in these quality assessments that have been carried out by the state organization to which you referred? And also, I don't quite understand how private hospitals would continue to survive in a situation where they would no longer set their own tariffs and they would no longer control their own supply sources. And when there would probably not be immediate payment for the services they receive, how would they do that? And then just secondly, a question. In the UK, the NHS employs 1.7 million people. 1 million of those are just in the bureaucratic side. They're not involved in healthcare delivery at all. This costs 2.3 trillion rand. Where on earth are we going to get the skills to run a system on that scale, because their population's only about 7 or 8 million larger than ours? I don't quite understand.
Healthcare needs a different. Because can I answer that?
Yes, please.
So in terms of the Office of Health Standards Compliance, they haven't started on the private sector. They will at some stage, so we don't really know. I don't think the assumption in many people's minds in South Africa that the private sector has the best quality in the world. I think it has its challenges as well. It's obviously not at the level of the public, but I would guess that if the office went into the private sector, it's going to find some skeletons maybe crawling out there. But anyway, I think in the other question that you said, how would the facilities survive if the NHI sets the price of the tariffs at which they're going to be set? I fundamentally disagree with any price setting in a structure like that. And I think in healthcare systems, the focus should not be on what's the price being paid, but what's the quality of the outcome. And if a system can be structured in such a way that it's measuring that, and I mentioned the Professor Michael Porter from Harvard and this work that they're doing, and it's the absolute focus of that thing is that organization is to focus around that. What's the best outcome? And the interesting results are that they're improving their outcomes and reducing their costs. That's a fundamental about that focus. Price setting in healthcare, because all you do, if you say to a doctor, well, we'll pay you X for every time you see someone, you're just going to sausage factory that practice and pump through as many doctors as possible rather than focusing on the quality of the outcome. And then your third question, I can't remember, which was...
where are we going to get the skills?
Yeah. Well, hell, I don't know. I think it might talk to the question though, and this is a key issue for me around this NHI policy, is there's been so little work done. That is the type of question that would have been in the technical analysis leading up to it. Okay, we want to build a system, and that's great, and maybe we can get it to work, but one question would have been in an assessment over that 10-year period in which the committee's been in existence, but none of those things have been assessed. So when you answer that question, nobody can really answer it.
I think I'll eventually guess. I'm also actually quite familiar with Michael Porter's work, which actually looks at value more than competition, right? And I think what they do is they redefine the way that we measure healthcare value, right? And they change like how soon you can get back to work, and they add an economic value to that. And I think there's a lot of thinking going around that, around efficiencies and where the skills will come. We actually have quite a big industry. It doesn't mean that people have to be employed by government in order to work in the NHI. We have some of the most successful health companies in the world. I think Mediclinic is one of the best. Discovery has got global. There's a ton of skills that sit in there, and they're not indentured to Discovery, so they don't have to work there forever.
So I think if we get the right kind of mix, we can get the skills. The skills exist. We're not working for zero base. We're already running a 480 billion rand health industry with the skills that we have in the country. When it comes to hospital efficiencies, if we look at the amount of hospitals we have relative to the amount of patients we're serving, there's a gap. So there's some efficiency opportunities there. You know, so many of them are running at probably like 30 or 40% occupancy, right? And I think if we push those up and they're sitting with assets that they could sweat, and if there's a cross-sharing between the public and the private sector, you can have much more efficient businesses. You may not have the big numbers, but you're much more efficient and your ultimate profit return could be better. But I think what we need to do, though, is start building different sides of struggle. And I think the first point is let's fix primary healthcare collectively. Let's not treat it like a public sector, private sector kind of a thing. Let's all mobilize the industry around a set of benefits and say, look, we have capacity in this area, you have capacity in that area, and we organize locally. And we deliver a quality product over time. Nobody says that the public sector can do it on their own or the private sector can't. You know, in fact, none of the private sector treatments have been assessed for quality. Right? And I think one of the findings of the health market inquiry found that quality is actually quite low in the private sector because of that information asymmetries. But this is a management organization problem. It's not a funding problem. Right? I think, and like I said, I think there's a ton of clever people in the room and in the country that when we start changing our perspective around the problem we want to solve, rather than organize politically and ideologically of what we don't want to do, we're not going to get to the result that we want to. So the UK is expensive because of the way that system is structured. You can have hymen replacement under the NHS. So you can become a virgin again and have the British government pay for it. You know, so the scope of benefits are also what drives the cost. But I think the opportunity that we have is that we can learn from all these people. They're also good systems. You know, I mean, you spoke about economic growth leads to healthcare, and sometimes it's the inverse. Korea, or South Korea, invested heavily in universal health coverage, and they've had it for a long time. And we know that growth story. So did Japan. So did China, at a time when they hadn't got to the economic levels that they are now. And investment in health is not a leakage. It's an investment because it improves human capital. And I think at the moment in South Africa, what we have is we have an aggregate demand problem. We don't have a capacity problem. We need more consumers. We need more people who can buy to allow the economy to expand. So I think we just have to change our perspective. But there are opportunities and there's a lot of learnings. And I think the stuff that Michael Port is doing is very, very interesting about how we value health.
Thank you very much. Ladies and gentlemen, I think our time is running out for tonight. I think we can probably talking about this topic forever. But thank you very, very much. I think it's a lively discussion, but it just shows you, you know, it's not just about different perspectives. The reality is there's a stark inequality, and we need to find urgent solutions. And we need to also look at alternatives, and that's one of the things we've been specifically said. We haven't seen alternatives actually presented to the public. We don't know. In that regard, I mean, there's interesting approaches. We've mentioned in our submission, you look at Ireland, for instance, they actually had a very apolitical approach. They also looked at universal health coverage, how to do it, and they established a committee from all political parties, and actually having explicit, I'm not saying it's the ideal solution and it's end all and be all for it, but it's an approach to achieve universal health coverage, and I think that is definitely what we saw tonight. No one is against universal health coverage. It's just how do you do it in our country, and how's the best approach. Thank you very much. We've got some snacks outside and drinks, and if you want to speak to any of our speakers more, you're very welcome to. And I'm very glad it could be so lively. We love it, we need it, and this is a platform to do it. Thank you very much.